Advanced airway procedures, including endotracheal intubation, are integral in the management of critically injured or unwell patients. Intubation protects the airway from aspiration, maintains airway patency, and enables delivery of controlled ventilation to manage hypoxia and hypocapnia. Indications are as follows. Intubation pre-hospitally is often amid a chaotic or stressful environment, and a calm decision-making process is required. A structured, stepwise approach is needed to ensure no key steps are missed in the preparation and planning of the intubation. To do this, RSI checklists are often utilised. It is crucial that all of the equipment required for intubation, as well as those needed in managing a failed or difficult airway, is readily available and within easy reach of the airway assistant.
My name is Stephanie and I'll be the team leader in the first intubator. Stuart, you'll be the airway assistant. Are you familiar with all of the equipment?
I am.
So first I'll get you to hand me the bougie, and when I say railroad the tube over top.
Okay.
Ted, you're in charge of the medications. We've previously discussed the medications, the dosages and time. Do you have any questions?
I don't.
I'll also get you to monitor the patient vital signs, and if there's any change, please let me know.
I will.
Alright, we're ready to complete the RSI checklist.
Okay. Has the patient been assessed for a difficult airway?
They have been assessed and there are no predictors identified.
Has the patient's position been optimised?
It has. They're currently in the sniffing position at the head end of the stretcher.
Has the patient been adequately pre-oxygenated?
They have. They have nasal cannulas running at 15 litres per minute. Also have a BVM with a peak valve set to 5 centimetres of water running at 15 litres per minute.
Can the patient's hemodynamic status be optimised?
It has been optimised to IV lines and a pre-hydration of 10 ml per kilo.
Has comprehensive patient monitoring been applied and working?
It has been applied. The temperature and blood sugar were within normal limits. The blood pressure has been set to 3-minute cycles.
Is there patient IV access with fluid connected?
There is. There's 2 18-gauge cannulas in the ACF and it's free-flowing.
Is the suction on and working?
It has been checked.
Is the following equipment available and checked? 2 laryngoscopes?
Cited?
A video laryngoscope?
Yes.
An ETT?
Yes.
A spare ETT?
It is, and it's one size smaller.
And are both cuffs checked?
They have been checked.
Is there a bougie?
There is.
Is there a stylet?
There is.
Is there a 10 ml syringe?
Check.
A tube tie?
Cited?
A manometer?
Yes.
An OPA?
Yes.
2 MPAs?
Yes.
An LMA available?
They are available.
And is there a surgical airway available?
The surgical kit is available.
Okay, we're ready for RSI.
We're going to administer 105 milligrams of ketamine and 105 milligrams of succinylcholine. Plan A will include mask ventilation and tracheal intubation. I will have the first intubation attempt and use a bougie. If I'm unsuccessful, I will have a second attempt after making a change. Between attempts, we will bag valve mask ventilate the patient to ensure they return to their pre-induction state. If unsuccessful after the second attempt, we will change operators and Stuart will attempt the intubation. If he is unsuccessful, a failed intubation will be declared. Plan B is maintaining oxygenation and supraglottic airway insertion. There will be a maximum of 3 attempts. Plan C will be the last attempt at rescue oxygenation by bag valve mask ventilation. We will use a 2-person technique with the patient being ventilated to hospital and the surgical airway kit being prepared. If we have a can't intubate, can't ventilate situation, a surgical airway will be performed as Plan D. This will be a scalpel cricothyroidotomy. We have palpated the structures and marked the cricothyroid membrane. Are there any questions or queries? No? Okay. Before we demonstrate intubation, let's have a quick look at some of the anatomical landmarks. Here you can see the uvula and the platoglossal arches. Behind that is the posterior wall of the oropharynx. At the top of the screen, you can also see the base of the tongue. As we go a little bit further down, you can see the tip of the epiglottis. The space between the tongue and the epiglottis is the vallecula and where the Macintosh blade gets seated. Here are the structures of the larynx that we are looking for. We can see the posterior arytenoid cartilages and the interarytenoid notch. Here is the ventricular folds or false vocal cords and the true vocal cords. Between the cords is the glottis and the location for placement of the endotracheal tube. Behind the posterior cartilages is the esophagus. Now the checklist has been complete, we can intubate this patient. Administer the ketamine, taking note of the time. Administer the succinylcholine. Note when the patient is apneic. Wait for the fasciculations to stop and note when there is loss of jaw tone. Open the mouth with the right hand using a scissoring action to protect the oral structures from damage. Gently insert the laryngoscope into the right side of the mouth and sweep the tongue to the left to create a space down the right-hand side. Gently progress down until you see the epiglottis. Advance the blade until it lies in the valvular groove and apply traction at a 40 to 45 degree angle. The angle and position will determine cord exposure, not the force applied. Look for the laryngeal inlet and the structures previously identified. If you're unable to visualize the cords, consider suctioning, releasing or reduction of cricoid pressure if applied, external laryngeal manipulation or burp, protracting the right upper lip, practitioner and patient positioning with consideration of more head lift, utilizing a different laryngoscopy blade or video laryngoscope. Announce the graded view, and now that you have a view, don't take your eyes off it. Ask your airway assistant to pass the bougie. Place it into the trachea and feel the clicks of the tracheal rings. Instruct the airway assistant to railroad the tube and then hold the bougie. If they have trouble railroading the tube, they may need to twist it a little to assist. Insert the tube through the vocal cords and 2 to 3 centimeters beyond. Remove the bougie, being mindful of any secretions that may be flicked out. Announce the length at lips and remove the laryngoscope. Inflate the cuff and listen for leak stream ventilation. Ask the airway assistant to hold the bag and securely hold the tube with their other hand. Secure the tube. Remove the nasal prongs. Confirm end-tidal intubation by continuous end-tidal CO2 monitoring. There must be at least 3 continuous readings without declining CO2. Squeeze the bag to assess the rise and fall of the chest. Auscultate to confirm air entry, including the left and right axilla, and auscultate to ensure no entry in the epigastric region. Other measurements of success and failure are listed here. Other management includes: we'll insert an oropharyngeal airway as a bite block. Assess the tube cuff pressure using the manometer, as overinflation can lead to ischemia of the trachea. The cuff pressure and depth of insertion needs to be assessed frequently. Reassess the patient's vital signs. Once the tube is confirmed, appropriate sedation and analgesia needs to be considered. If a fentanyl midazolam infusion has been prepared, then secure that. Otherwise, titrated aliquots of fentanyl and/or midazolam should be administered as required. Continually assess for signs of weaning of the sedation or paralysis. For example, lacrimation, increasing heart rate and blood pressure, diaphoresis, spontaneous respirations or movements. Insert a nasogastric tube. The oropharynx should be suctioned frequently to decrease the risk of microaspiration. Tape the eyes shut gently to prevent the eyes from drying. Maintain normothermia with the use of the car heater and/or self-warming blankets. Consider the use of a cervical collar to minimize movement of the head if required, even in a patient with no spinal concerns. Also, an appropriate and timely hospital notification. Furthermore, a post-intubation debrief should be conducted as soon as possible after the event. This identifies technical and human factors that could be addressed to improve safety of future intubations. Complications can occur at any time during, whilst in situ, or after extubation. The most commonly encountered complications by paramedics would be those at the time of intubation. Some of these include esophageal intubation leading to hypoxia and hypercapnia, bronchial intubation resulting in ventilation of only one lung, trauma to the lips, teeth, tongue, and laryngeal structures, which may result in bleeding or foreign bodies, possibly obstructing the airway or increasing the risk of aspiration, and physiological changes as a result of laryngoscopy and intubation, including tachyal bradycardia, hyper or hypotension, arrhythmias, hypoxia, and raised intracranial and intraocular pressures. Listed here are commonly encountered problems and possible solutions to work through. Pause the video and work through the listed problem-solving suggestions as required.